Hello, everyone. Good afternoon for those on the East Coast, and good morning to anyone, I guess, west of the East Coast. But thank you for joining today's webinar, Baker Tilly's webinar on key considerations in determining fair market value, particularly for the life sciences industry. Wanted to first start off by introducing ourselves. So my name is Mark Scallon. I'm principal here with Baker Tilly and its life sciences consulting practice. And I lead the compliance and ethics service offerings for the life sciences industry at the firm. I've been doing this for about 25 years now at various places and really work to help identify compliance-related risk for our life sciences clients and then putting some solutions in place to address them, of which our fair market value services are just one of those. So very happy to be here on this webinar today and walk you through the content that we're going to share with you today. Valerie, go ahead and introduce yourself.
Hi, I'm Valerie Burkholder. I'm an experienced manager at Baker Tilly. I have been in the pharmaceutical industry for about 35 years, previously with Eli Lilly and Company for a 28-year career. I've been consulting since I left Eli Lilly. In my expertise realm of expertise is fair market value and spend transparency reporting primarily. So I do a lot in that space, and I'm happy to be here today.
Great, thank you, Valerie. So just to go through our learning objectives here, the content of what we're going to go over with you today, we actually presented live at a conference a few months ago. It was very well received, and so we decided we also wanted to share it with a broader audience through this webinar. But really, the learning objectives here are really to go through some of the industry standards and guidelines with regards to fair market value, but only going to kind of go through those industry standards briefly. What we really want to spend a lot of time on is kind of going through what are the common challenges that manufacturers face. And a lot of what we're going to share with you is based on the over 100 clients that we're currently working with on their FMV solutions. And so it's a pretty big sort of subset from which we've been able to identify the challenges across the industry. We're also going to talk about and look at some key factors and nuances to consider. There are a lot of things that a lot of people don't think of that pertains to FMV that actually does need to be taken into consideration, some very nuanced things. So we want to go over that with you, and then also go over some considerations for some effective frameworks that you can maintain to navigate those challenges and maintain compliance and integrity of your organization and can keep contributing to the culture of compliance that you are creating at your individual organizations. So those are the learning objectives. Just to kind of get us started, we want to first kind of talk at a high level here and sort of set the stage for what we're going to talk about in more detail. And really, it's based on the idea that oftentimes a lot of people who work in this space think that fair market value is kind of a set number for a particular key opinion leader or healthcare professional. But in reality, it's really more of a fluid range of numbers, right? Things like qualifications and expertise, for example, can and should dictate where an individual key opinion leader falls around compensation and remuneration for contracted services. But on a global basis, there's other considerations besides just qualifications and expertise. And a lot of it has to do with things like market conditions, right? Like hyperinflation in certain countries, like recently in Argentina and in others. Also, the scarcity of particular specialties or specialties in a particular country that you may be engaging with. That could result in changes to the actual range itself. And so those are the kinds of things that we want to talk about. This is not going to be sort of a beginner's course, if you will, on FMV. We're not going to go through and define FMV for you, tell you, why it's important, or, it should be assumed that that is already known, right? We want to talk about more of the nuanced challenges that companies are facing. Another thing to consider, right, is risk tolerances vary, right, by organizations. So some companies may want to push the envelope a little bit more. take a little bit more risk and push up their FMV rates to be as high in the range as they possibly can. Others are very risk averse and they want to go to the opposite side. And then there are some companies that operationally want to be more efficient and therefore set an operational rate at 65% of the at the 65th percentile of any given tier. Whatever you choose to do, one of the really key considerations there is that you need to make sure that the methodology you are using, the baseline methodology that you are using in developing those rates, is a robust and defensible methodology, and that any of the considerations we're going to talk about today that results in you having to adjust further your FMV rates as it may stray from that baseline standard methodology, you need to just make sure that you are really documenting that and having that part as the official methodology to provide the rationale as to why the rates are what they are that you are compensating your key opinion leaders and HCPs with whom you contract. So just want to set the stage there with some of those sort of high level considerations before we kind of break them down and go into even more detail. Before we go there, though, I think it makes sense to at least level set around the different valuation approaches, but in particular, the valuation approach we're talking about in the context of this discussion today. So as a lot of you may be aware, there are two sort of valuation approaches for developing FMV rates for compensating key opinion leaders. One of them is the cost approach, or also known as the cost buildup approach, and the other is the market approach. The cost build-up approach is really the most common one and referred to really as kind of the standard approach for the industry. And the reason why is because it is the most defensible, and reasons why is because it takes very objective data as sort of compensation survey data specifically, sort of as the basis for the methodology. So it's data based, right? It's objective and not subjective at all. Whereas the market approach is a bit more subjective, because that is really a benchmarking approach where you would just send surveys out to the industry and say, hey, what are you paying these specialties in these countries? Consolidate all that information and send out that database. Obviously, that is less defensible because there could be some payments or rates above fair market value that's included in that data set. So you may inadvertently be using above fair market value data in the rates that you are using to compensate KOLs. So again, cost approach, which Valerie on the next slide is going to break down in more detail of what that actually looks like, is the valuation approach that we are referring to throughout this presentation. So, okay, Valerie, if you want to maybe go walk through what that actual cost approach methodology is, and then we can go into some more detailed considerations. Go ahead. I think you're muted, Valerie.
Sorry about that.
No
The cost approach is a calculation that's based on objective compensation data. And then there are some adjustments that are made to that data to account for the various activities that you would be paying an HCP to do. So we start with base compensation data, and that physician salary data is obtained from diversified country-specific objective income sources. So it is the actual income of an HCP at a particular specialty. We take that data and then we add a couple of adjustments to it. So the first adjustment is that you need to recognize that these HCPs are already employed full-time. They already have full-time jobs. They're working 40 or more hours a week, and you're engaging them to do something in addition to that. So there is an adjustment that is added similar to what you might consider an overtime adjustment. The second adjustment is an adjustment to recognize when you're requiring these HCPs to work, which is often during times when they would not normally be working. So you might have a weekend ad board or an evening speaker program, for instance, and there's a compensation adjustment added for that. Similar to like what you would consider if a nurse who may work the third shift versus one who works the first shift might have a higher compensation because of the shift that she's working. So we take that base compensation data, we add in those two adjustments, and then we divide it by the number of hours worked, an annualized number of hours worked, and then that gives us our FMV hourly rate. So when we have that hourly rate, there are some important challenges that is presented. And so we're going to talk about a couple of those things, and we'll talk about them, a few of them in more depth. But to start with, one of the things that we often see is that the calculated FMV is different than the perceived FMV. And what I mean by that is when we calculate the FMV, it's based on that compensation data. It's based on objective and transparent data. While someone working in the field might think, oh, well, that specialty should be making more, should have a higher hourly rate than this specialty, or that seems low to me. A lot of times it's simply because there's a perception that is actually higher than it really is. So we're going to actually talk about that. One example of that here in a minute. Another one is subspecialties. There are a lot of subspecialties, and what we notice in the FMV world is that there are new subspecialties. As diseases progress, particularly in the rare disease space, there tends to be new specialties that crop up, and individuals may be more harder to engage from those new subspecialties. So we'll talk about that a little bit. And then Mark touched on this a little bit with some of the OUS countries where either the inflation rates have, or the economies are not stable, or those countries that are high on the corruption perception index. A lot of times you'll see the business pushing for higher rates when it may not be appropriate due to that perception of the corruption index. So, and then on the other side of the coin is the KOL tiering. So Mark talked about that a little bit as well. We want to look at the level of expertise of the individual that you're engaging. So the KOL tiering, it can be time and labor intensive. You have to review CVs. You have to be able to collect information and use that information to adequately determine what the level of expertise of that specialist is. And those qualifiers can differ by country and or region. In the US, you see a lot of publications, a lot of clinical trials. That data is easy to obtain. May not be the same in every other country. So you may have to work a little bit harder to find those expertise, be able to find where that expertise is. And then this process is prone to bias and human error, right? It's people looking at CVs and deciding whether they meet the criteria or not. And then the fourth piece is the availability of information for tiering. And, I've done a lot of tiering in my career, and, I've seen CVs that are 135 pages long or more, and CVs that are 1 page long. So there's a different level of depth that individuals will put into their CV, and especially if they don't realize what the importance is of how we're using that CV to tier. So we're going to talk about a little bit about KOL tiering and how we can approach that and approach those differences. So the first thing we're going to talk about is on the fair market value side of the coin. So there are many challenges, and the first one I mentioned was the calculated FMV versus perceived FMV. And that is to say that perceived FMV can exceed the calculated FMV. Because individuals in the business feel that someone is more specialized. And a good example of this is pediatric specialties or neurology. both of those specialties tend to have a lower FMV than what is often perceived. And we're going to go a little bit more in depth into the pediatric example on the next slide. Also, regional expectation can be driven by US rates, the economic considerations, or can include non-compliant influences. So a lot of times you will see that the business is comparing rates outside the US to rates in the US, and those are very different. So occasionally we have to have some mitigation strategies, or we have to look at nuances specific to that country. And we'll talk a little bit about that as well. And then there's the subspecialization, specialty areas or nuanced subspecialties, especially within neurology and endocrinology, require additional research to ensure that those nuances are considered. So while your standard FMV may not consider such things as rare diseases or a subspecialization, you can certainly build that into your FMV on a case-by-case basis. So we'll talk about that a little bit. And then the third thing is emerging specialties and rare diseases. And one of the things that we've seen recently is a lot of non-physician HCPs, like your NPs and PAs, are playing a bigger role in those specialties where physicians might be in short supply. And so we want to make sure that we're calculating that and considering that. And then also the data for specialties in that rare disease space may not be as readily available, particularly for the non-physicians. So meaning that the compensation data may not be as granular for those specialties. So we may need to adjust our process a little bit in order to do that. So the first thing we're going to talk about is the pediatric specialties. So one of the challenges we see, and we see this frequently, is that when we provide FMV rates, the reaction to pediatric specialties is, oh my gosh, those are lower than I expected because they're specialists, which is true, but they are not compensated as highly as their adult counterparts. So when you take a pediatric endocrinologist versus an adult endocrinologist, their compensation levels are very different. And there are some reasons for that. The first of which is their lifetime earning potential for adult physicians on average is 25% higher than those of pediatric physicians. And there's a couple reasons for this. One is that in pediatric medicine, they are not nearly as procedure based as they are in certain adult medicine counterparts. So their subspecialties, those subspecialties that are procedure driven, have a much higher lifetime earning potential than the outpatient or less procedure driven subspecialties. And then the third piece is that adult medicine subspecialties often require a shorter length of training than do pediatric subspecialties, which might make you think, well, then if it's a longer length of training, it should be valued higher. But what in reality is happening is the compensation data, their ability to realize their full compensation is actually delayed. So their lifetime compensation is less. So we have a couple of mitigation strategies that we can work with here. So the first is to understand that the cost buildup approach methodology is based on compensation and the value of the HCP's time. So it's directly related to the compensation they receive. So if you're working with a pediatric specialist, that compensation data is going to be lower than if you're working with a non-pediatric specialist. And then the second piece is to fully understand the scope of the specialties. So part of our job when we're working with companies on FMV is to really understand who they are engaging and the nuances of that specialty or subspecialty so that those can be considered. There may be special certifications or rare disease experience that may warrant an additional adjustment, which we refer to as a scarcity adjustment, to say, there are not that many experts with this expertise in this disease. Therefore, there may be a justification for that scarcity adjustment or for an exception.
And just to add to that, Valerie, not even just a scarcity as it pertains to the specialty itself, but also to the geography. So if there is, let's say, there's a particular pediatric specialty of which there may be plenty in the United States, there may be very few in a specific geography. And if you're looking to have an FMV rate in that geography for that specialty, the scarcity of that specialty in that geography could warrant an additional adjustment, like Valerie just said. So just wanted to add that.
Thanks, Mark. And then the second challenge with FMV that we're going to talk about is those regional expectations. Again, we have talked about how those rates outside the U.S. can often be influenced by rates in the U.S. There are different additional economic considerations, or they could include additional fees that are non-compliant. And so we want to make sure that we're addressing those and seeing the whole picture of the outside the U.S. So one of the things that we looked at is in U.S. and Canada, the wages for highly skilled, highly educated workers are high, but they also have fewer physicians per capita than most other developed countries. And in the US and Canada, doctors typically complete 4 years of undergraduate study and 4 years of medical school prior to their residency, whereas in parts of Europe, you can study medicine in a 5 to 6 year undergraduate course. And then in some markets, economic conditions like inflation or currency fluctuations can really affect the FMV, or those non-compliant facilitation fees can drive up the perceived FMV. So while the FMV that we may provide is adequate based on compensation, the perception on the ground is higher because these facilitation fees are built in, which are not compliant with FMV. So we have some mitigation strategies there. And one of the things that we like to do when we're looking at OUS data, particularly to address the comparison to the US or Canada, is usually utilizing a cost parity approach, which is a great way to illustrate the value of the actual payment. And for example, you can take look at what is the average monthly cost of housing in that market, and then compare it to the FMV hourly rate to kind of add in some reasonableness to say, okay, this is what you would pay for rent for a month in this country, and this is the hourly fair market value rate. And then that gives you a nice baseline for how it appears in the local economy. And then the second is to consider those economic conditions and adjust for those if needed. So Mark mentioned Argentina. There's hyperinflation in Argentina. There are countries that have currency that's not very stable, and so there are changes that take place frequently. And we can take those into consideration. So we want to understand what those market conditions are, and we do take that into consideration when we're looking at particularly FMV outside the United States. And there are certain markets where that's more of an issue. Latin America is one of those. And so we will look at those and make those adjustments. And then, but we also want to make sure that we're not being influenced by those non-compliant fees that would put the company at risk if we're in a country where they may be trying to put in those facilitation fees and other things like that we wouldn't want to add into FMV because it's not compliant and it does present risk. And then in less developed countries, it may be appropriate to include a country level adjustment to account for the limited supplies of physicians per capita. So there are some countries where there may be a larger population, but a smaller number of physicians. So it may be appropriate to add a country level adjustment to that. Or you could look at individual specialists, and is there a shortage of a certain specialty in a certain country? So those are all things that we would want to look at. And, it's just important to realize that when we do an FMV project, we're considering all these things. So we're not just calculating the FMV rates and tossing them to you and saying these are the FMV rates. It's a process. There's a calibration process. There's a process to make sure that all of these nuances are being considered and that we're, giving you the best possible compliant FMV that we can. And then the third one that I'm going to address is the scarcity. And so we see this a lot. We work with a lot of companies that are in the rare disease space, and we notice that the non-physician HCPs are playing a much bigger role in those specialties where physicians are in short supply. And in the rare disease space, one of the places we see this is with genetics. So engagement with non-physicians in the genetic space is increasingly common. A 2019 study published in Genetics and Medicine showed that 39% of patients are waiting more than 3 months to see a clinical geneticist. So we're seeing that some of these NPs and PAs are stepping in to take some of that load off of those physicians so that the patients do not have to wait as long. In the US, 40% of genetics providers are located in only 5 states. And Mark touched on this earlier. There may be geographic considerations. 14 states had 5 or fewer currently certified clinical geneticists, and 1 state had none. So that is definitely something we would want to take into account when we're looking at compensating geneticists or NPs, PAs, other non-HCPs that are working in the genetic space. And then in the medical genetics service delivery team includes many providers, genetic counselors, metabolic dietitians, physician assistants, nurses, researchers. We would want to include all of those. So that's just, we need to keep an open mind and know what the landscape is. And in that rare disease space, we're seeing a lot of this. So for mitigation strategies, again, we want to fully understand the scope. This means working with the clients to understand who they're engaging and what the nuances are to those specialties or subspecialties. Are there special certifications or rare disease experience that they're specifically looking for that may warrant that scarcity adjustment or be a justification for an exception? And then recognizing that designation as an ultra rare disease reduces the pool even further. So if you are working in the ultra rare disease space, that can be a justification for an additional adjustment as well. So when we talk about the level of expertise, now we're going to jump into the KOL tiering side of the FMV equation. So when we're talking about thought leader status, it is typically based on objective assessment of expertise and qualifications. We basically have four qualification areas that we look at. One is employment. The publications and clinical trials is the second, speaking and advisory is the third, and associations and journals is the fourth. So in employment, we're looking at the length of employment, affiliation with leading institutions, leadership positions, fellowships, what are they doing in that employment space? For publications and clinical trials, we're looking at the frequency of publications in leading journals. How often are they participating in clinical trials, and what is their role in that clinical trial? And have they received awards from independent bodies, or are they presenting at congresses and presenting abstracts or full talks? And speaking and advisory, we're looking at, are they speaking or chairing sessions at those conferences? Are they participating in treatment guideline committees and helping to create those guidelines? Are they in advisory positions in a government or a national or international organization? And then the last one, associations and journals. We're looking for those leadership roles in national or international medical associations. Are they an editorial board member for a leading peer-reviewed journal? Are they serving on those medical or scientific committees for those medical associations? So all of those things will play into what their tier level is for for that KOL tiering, that level of expertise. So, of course, there are many challenges with the KOL tiering and engagement process. It's a manual process. It's costly. It's tedious. It is prone to error and bias. Highly specialized or rare disease KOLs present extra challenges because there may be very specific criteria that is consistently applied to properly qualify someone as a rare disease KOL, which may not exist in a standard tiering criteria. And then KOLs may be unable to provide an updated CV document. As I mentioned before, I've seen a lot of different CVs, and I can tell you there are some very well qualified KOLs who just don't have a robust CV, and they may not be able to provide you with that in a timely manner. And then additionally, in those highly specialized or rare disease spaces, KOLs can be very much harder to identify. There may be a scarcity of them, or it may be simply that the information in those CVs does not adequately state that they are experienced in that highly specialized area or that rare disease. And then once you identify your KOLs, there can be steep competition to engage, especially those that are specialized or in rare disease. And then your high level in-house professionals are the ones doing this work. So you often have your medical team or your medical affairs team, your medical officers performing this time-consuming manual CV review, as opposed to focusing on, the more objective parts of their function. So in order to meet this challenge, the solution is using a data-driven process. And that ideal tiering process is consistent, objective, efficient, and standardized. And the way to do that is by using a data-driven process.
Yeah, so just to make a few comments here, Valerie, one of the things that we, in working with, like I said earlier, over 100 companies and working with them on their FMV methodologies and FMV solutions, one of the things we heard over and over again from our clients is their frustration and problems or challenges that they were having with the tiering part of their FMV solutions. And so, there is a number of resources out there that has vetted qualification data for millions of key opinion leaders around the world. And one of the solutions that we came up with was we developed our digital tool called KOL Now, which essentially leverages that qualification data that a number of companies out there gather. It's all based on publicly available information. And we purchased that qualification data and applied our own algorithm to that data to kind of pre-tier over 8 million key opinion leaders around the world. So when you look at the list of challenges on this slide, having that data-driven approach where you have vetted publicly available qualification data for millions of KOLs so that it eases the burden and the inaccuracy and inefficiency of manually tiering, it's actually pretty powerful and actually kind of completes the circle on having a very sort of effective, efficient overall FMV methodology, because tiering was always sort of that outlier thing where it was like, yeah, our FMV methodology is very robust and great, except for the tiering part. Well, this sort of completes that circle, right? And so in the next slide, Valerie is going to kind of walk you through a case study of how we did that for a client and sort of the advantages that came out of it and the outputs and results that came out of taking more of a data-driven approach to tiering than a manual one. So go ahead, Valerie.
Thanks, Mark. We do have a case study here. A top 25 global pharmaceutical company was doing manual tiering and came to us and wanted to engage for the automated tiering. With the manual tiering, they were engaging a high number of healthcare professionals and non-HCPs in a variety of settings. They were manually tiered using CVs to determine their level of expertise and their FMV rate. And obviously, we've talked about this. It's a time-consuming, resource-intensive tiering process, which is at risk for bias and human error. What we were able to do was tier those through our automated tiering tool. 74% of those KOLs showed an increase in their hourly compensation rate within the parameters of FMV. So indicating that they were tiered, they were not tiered correctly, therefore not assigned the right FMV. 72% were tiered at a higher tier or had no change to their tier level assignment. And there were 28% who showed an initial decrease in their tier level, but that initial decrease was primarily due to increased objectivity in tiering and specialty assignments. So in some cases, it was just a matter of the individual was not identified in the right specialty. And so therefore their FMV rate was different than was changed simply because their specialty was not correct. So that automated data-driven process can really streamline that resource-intensive process and eliminate a lot of that, bias and human error. So you get a more objective tier level and a more objective view of that HCP's level of expertise. So in conclusion, many companies are partnering with HCPs more and more each year, and the FMV will continue to play an important role. In the US alone, the number of physicians receiving payments as reported by Open Payments was increased 6% from 2022 to 2023, and the number of non-physician payments increased 11%. As we all know, the non-physicians became reportable in the last couple of years. And so we're seeing an increase in those payments as well. And it can be challenging to develop those defensible methodologies to appropriately compensate when you want to engage with those HCPs. But there are definitely things you can do to mitigate those challenges. The first is utilizing that data-driven tiering process, and then fully understand who you're engaging with and their unique qualifications. As I said, when we're doing these FMV projects, we're working one-on-one with our clients to make sure that we're understanding all of those things. And it's definitely an interactive process to understand all those nuances and make sure that we are ensuring those unique qualifications are being considered. And then we're also looking to consider the global landscape and how that might impact the perceived FMV rates, and then help companies to understand why those perceived FMV rates might be a little bit higher and why they may or may not, be able to be adjusted based on the conditions in a particular country.
Great, thanks, Valerie. And a couple of things to add here. First, this is it for the slides, right? So if you have any questions, and we do have one question, which I'll get to in a second, but if you do have any questions, now would be the time to type them in so that we can answer them now. We did build in a good 15 minutes to respond to questions. But before I go there, one thing to just add a little bit of color to this, right? I mean, Valerie did say companies are partnering with HCPs more each year. And, couple that with the fact that if you were at the big pharma conference a couple of weeks ago, Mary Reardon from the OIG gave her, her annual talk at that conference where she again reiterated that this is something that the government is looking at, right? How you are compensating them, is still something that they're going to be looking at, which means having this robust, documented, and effective, either through data-driven approach or otherwise, methodology for compensating key opinion leaders is still just as important as it has ever been. So just kind of wanted to end with that statement there. We can now move to Q&A. So Valerie, if you want to respond to this one, we have a question asking, do you have any clients that don't use multiple tiers and use only one FMV range based on the HCP specialty?
We do not typically have clients that do not tier. And the reason for that is because there's inherent risk in that. If you do not tier your HCPs and you pay a single rate, if you happen to be on the high end of that FMV range, you could be overpaying. So if you're looking at a physician who is either new to their field or they're more community based, they're not doing a lot of publishing, they're not doing a lot of clinical trials, they don't have a larger reach or influence, and you're paying them at the same amount as someone who is much more well known, then you are overpaying, and so that is a risk. There's an inherent risk involved with that. So when we provide FMV, we do provide the tiering criteria for you, so that you don't have to create that tiering criteria from scratch. We'll provide it to you, tell you what it is, and then work with you to learn how to look at those, learn how to use that tiering criteria. But I don't know that we have any clients who are paying at just one tier that I can think of.
Yeah, I'll caveat that with we have had a few clients for a particular region where they wanted to take this approach. In particular, the Asia Pac region. So in the Asia Pac region, more than any other, we have had requests from clients there that they just want to pay all HCPs for a particular specialty at the same FMV rate or within that one range, and not have a tiering criteria based range like you would in other regions, particularly in North America. So hopefully that answered your question. We've had one or two little sort of outlier requests from clients to do it with just one FMV range, but the vast majority of the clients that we work with does not do that.
The other major exception would be France, because France has a law that states how much you can pay an HCP. There's no tiering. They're tiering in France. Everyone's paid the same rate, regardless of their specialty or tier, because the rate is fairly, on the low end of FMV, but it's mandated by law.
Another question just came in. What do you consider is the threshold for switching from manual to automated data-driven process, i.e. how many HCP engagements justify or make a switch worthwhile? I can start, Valerie, and then if you want to add, I'm just going to say it depends. Consulting answer. It depends. And one of the things it depends on is how many resources do you have that's doing that manual tiering, right? If you're lucky enough to have a lot of resources that do that, then your threshold's a little bit higher than an N of one compliance department that has to do it themselves, or if they just have one person in Med Affairs doing it. But Valerie, did you want to elaborate on that?
Yeah. So the way that we work with that data tiering tool, is by specialty by country. So even if you have a small number of KOLs, you would be basically paying for that specialty in that country. But like Mark said, it really depends on how much work you're doing and how confident you are that the tiering is being done correctly, because that's where the risk lies if the tiering is not being done correctly, or is being done by someone, by a part of the company maybe that's not really familiar with tiering and CVs and tiering criteria.
But to give you a more direct answer, I guess, with an actual number from what we've seen in working with our clients, particularly for those smaller emerging biotech, emerging med tech companies that have, just one person at the organization who's in charge of FMV and who's in charge of doing the tiering, it tends to become unsustainable. Is probably a bit much of a word to use, but it becomes much more value added to move to a more automated data-driven process for tiering once you hit about 50 to 70 KOLs that you're engaging with annually. That's usually when companies look to move on from the manual approach and really start to see the benefits of automated. So hopefully that answered your question. I'm not seeing any others right now. So maybe I'll just wait here 30 seconds to see if any more come in. Okay, I think that might be it. So I just want to thank you for joining us. Thank you for the questions. Those were very great. Those were great questions. Hopefully you found this helpful. And our contact information is up here on this slide. So if you think of another question that you may have, and you want to just send us a note directly, happy to field that and answer any questions that you may have. But again, hopefully you found this helpful. Thanks for attending, and it was our pleasure to do this webinar for you today. All right, take care. Goodbye.
Thank you.